My name is Kirsten Johnson, and I'm the incoming president for the Canadian Association of Emergency Physicians. And today's introduction is coming to you from the Gaspé region of Quebec, where I'm on holiday with my family. And since it's summer, I hope that some of you are able to take some time off to be with your families. Also, since it's summer, I'd like to thank you for taking the time to join us for tonight's second Cape National Grand Rounds. Just a reminder that our Grand Rounds will be featured on CAPE's website monthly for free. The next event, which will take place on August 12th, is Mid-Pandemic Marathon Fatigue. What can medicine learn from sport? So put it in your calendars. The speakers will be Haley Wickenheiser from the University of Calgary. She's a medical student, a 4-time Olympic gold medalist, Assistant Director of Player Development for the Toronto Maple Leafs. Dr. Marie-Claire Bourque is a psychiatrist and mental performance expert for the Toronto Maple Leafs, and Dr. Wanda Millard will be our moderator. She's a specialist in emergency medicine and a team physician for the national women's hockey teams in Canada. Based on your suggestions, we are working on CME credits, and we'll let you know more details on this very soon. This fall, our Grand Rounds will feature talks that were scheduled for the 2020 conference, but if you have ideas for future Grand Rounds, we'd love to hear from you. So email them to Christina Bova at cbova@cape.ca. Again, these events are free and available to everyone, not only CAPE members, but they do happen because of CAPE memberships, and CAPE is stronger because of its members. So please join us if you haven't already, and if you are already a member, a big thank you. I am honored to introduce the topic and speaker for today's second CAPE National Grand Rounds, which is the Canadian Armed Forces Health Services Response to COVID-19. Our speaker tonight is Major General Andrew Downs. He's the Surgeon General, and he will be interviewed by our Dr. Trevor Jane. For those of you who don't know, the Surgeon General is the professional head of the Canadian Military Health Jurisdiction, the advisor to the Minister of National Defence and the Chief Defence of Staff on all matters related to health, and head of the Royal Canadian Medical Service. The Surgeon General is also the commander of the Canadian Forces Health Services Group, which fulfills all military health system functions from education and clinical services to research and public health. It consists of the Royal Canadian Medical Service, the Royal Canadian Dental Corps, personnel from other branches of the armed forces and civilians, with health professionals from over 45 occupations and specialists in over 125 units and detachments across Canada and abroad. As Director General Health Services, the Surgeon General is also the Senior Health Services Staff Officer in the Department of National Defence. The Surgeon General is normally appointed to the medical household as Honorary Physician or Honorary Surgeon to Her Majesty the Queen. Major General Andrew Downs joined the Canadian Air Force in 1989 as a medical student at the University of Manitoba. During his career, he has served as the CEFCOM, CanadaCom, Canascom Surgeon, the RCAF Surgeon, and briefly the Director of Force Health Protection. In 2014, he was appointed as the Director of Mental Health. Major General Downs has been deployed on 4 international operations, including ones in Bosnia-Herzegovina, Italy, and as the task force surgeon in Afghanistan. He was also the commanding officer of the Health Services Unit and commander of the NATO multinational Role 3 hospital at Kandahar Airfield. As the Surgeon General, Downs is responsible for making policy recommendations on all matters of health relating to CAF members and reports to the Chief of the Defence Staff. So, it is my great pleasure to introduce Major General Downs and to also introduce our esteemed colleague, Dr. Trevor Jane, who will be moderating this session. So, without further ado, I'll hand it over to you, Trevor.
Good evening, General Downs. Thank you so much for joining the CAPE session tonight. It's really good to see you again.
Well, thank you very much for the kind invitation to be here tonight. I'm very much looking forward to our discussion and to spend some time with you. It's been a few years since we sat down together and had a good discussion.
Yeah, great, and we do appreciate your time. It generated a lot of interest and a lot of questions with regards to health services and their interactions with the civilian healthcare system. One of the questions, I'm going to jump right in. One of the questions that we got or we get is like, how what is the process for a province, for the healthcare system to actually ask help for the military? I imagine they just don't pick up the phone and call the local unit. What is that process to get support from the health services and the armed forces?
Well, that is a very important question, and one that we've had to deal with quite a bit, as you can imagine, over the past few months. The official way to get the Canadian forces to be deployed somewhere in Canada is for an official request for assistance to come from a provincial authority. So normally, the process is from the Provincial Emergency Measures Organization to, in our case now, the Minister of Public Safety, who then refers it to the Minister of National Defense. So that's the formal route that this takes. But typically, prior to the actual paperwork being submitted, there's a lot of conversation that goes on to determine what is in the art of the possible from a military response perspective, to better understand the situation and to provide advice on the language, so that we're not asked to do something we really are not well set up to do. So it's a collaboration initially, and then followed by the official paperwork to make it so.
When you see these, you use the term request for assistance. Like, how long was it for the COVID-19 process? Is it from flash to bang from the time that you heard initially conversations about getting your support for, in particularly Ontario, Quebec, and other regions? How long was that process in the making, or does it take in general terms?
Well, I think it depends. It depends on what the request is for. Some of the requests are in fact for, or have been for, fairly small things that we could deliver without too much difficulty. In the case of sending our personnel to long-term care facilities, we started having discussions on, and I'm even trying to remember exactly the timeline, but it was within a couple of days we heard that there was going to be a request. We shaped that request and got the response, probably within about 2-3 days. And in the meantime, we were starting to prepare our forces for that deployment. So it probably took another 3 or 4 days for us to get our people into position and ready to start the task that they had.
Yeah, there was a lot of visibility, wasn't there, with long-term care? There was a lot of media and social media and heat and lens on seeing uniformed soldiers go to long-term care. And we want to talk, I'm very interested and have some questions about that. But before we get to long-term care, were there other aspects that you were asked to do as a Surgeon General? Were there other things that maybe we didn't know happened for the last couple months with health services that they were involved in? Maybe were there other operations involved that we didn't hear about?
Well, there were, in fact, although one that you probably did hear about, but perhaps didn't realize the Canadian Forces was involved in, was the 5 flights that were sent to bring Canadians back from locations overseas. We deployed personnel on 2 flights to Wuhan, and we deployed a team to Japan to bring people back from the Diamond Princess. We deployed personnel to California to bring people back from the cruise ship, the Grand Princess. And we also sent a 5th flight to Vancouver, actually, to pick up people that were brought to Vancouver on an American evacuation flight. So that was, I think, an important role that we played. So we screened people before getting on the flight, and we escorted them back to Trenton, where they underwent quarantine quarantine for their 2 weeks. So that was probably the other big thing that we did as a Canadian Forces Health Services. There were other smaller things. For example, we provided a number of our personnel to assist the province of Ontario with contact tracing.
Oh, okay.
We provided advice to one province, as well as to one of the federal departments that was in the process of buying deployable field hospital equipment for use in various provinces wherever the need arose. We also were involved. The Canadian Forces was also involved in some isolated communities with our forces known as the Rangers, who are individuals as part of the reserve force who typically live in these communities and are called to respond to various emergencies and exercises and things like that. So their role was to set up infrastructure, perhaps a tentage, for example, outside a nursing station, something of that sort. So the Canadian Forces did play a role in that. And throughout this period this spring, we were looking at where we might be called to assist. And typically every spring we are called to assist in flooding, for evacuation of communities or to do sandbagging and things like that. So we kept some forces aside to do those types of missions. And those forces typically have a medical response that goes with them. So not specific to COVID, but still nonetheless part of our potential response to a request for assistance from a provincial authority. So those are just, actually one other example I wanted to point out of something we were asked to do, but it was to assist another federal department. That was the Public Health Agency. We provided some of our bioelectronics technicians to assist the Public Health Agency with testing and calibration of electronic devices that had been ordered, so ventilators, infusion pumps, things of that nature, because they needed extra hands, extra skill set to do this work. So that gives you a bit of a picture of the scope of things that we were involved with.
Yeah, so there's multiple channels, multiple facets besides long-term care. I think that was kind of on everybody's mind, and like I said, we'll get there, but multiple operations, and just so it's clear in my mind, each of those kind of had to go through that request for assistance process that you had talked about before, no matter how small or large the operation could be for the forces.
Yes, that's right. And in fact, there was even a request from one province for a transport ventilator, just a single ventilator, and that came through as an official request for assistance.
Okay. You mentioned about we touched on long-term care, which we're going to get into some detail. You mentioned some of the other things that the health services was involved in real time. Was there any planning or any things that health services thought about that wasn't utilized, or that you had on the books but haven't been executed that you can talk about, or did you kind of all bases were covered with the operations you mentioned?
Well, we had plans to do all sorts of potential tasks because, we didn't know what we were going to be asked to do, and over time we were seeing what our allies were being called upon to do. We were reviewing our contingency planning that had been on the books for years. We've had a pandemic plan in the military for many years, and so we were looking at all the different scenarios that had been built as part of that plan. So we were very much thinking one of our tasks might be to augment a civilian care facility. Of course, we expected it was going to be an acute care facility or acute care facilities as opposed to long-term care, but the concept is very much the same. Mm-hmm. So we had different force packages, if I could use that term, to respond to perhaps an isolated community. We had other force packages perhaps to augment a large hospital that might just need some overflow capacity. We had considered having teams to do testing, to do triage. We had the notion that we might in fact have to deploy a field hospital to a location. We didn't have to deploy any of those things, fortunately. I think we're very pleased in Canada, very lucky, I would say, in Canada to have avoided the worst of COVID-19 that so many of our international friends, unfortunately, have had to go through, and many are still going through right now. So luckily, we were not called upon to deploy these packages. But they are still on the shelf, if you will, and we could reconstitute them and deploy them in the future should the need be there.
Yeah, it's an amazing amount of planning, I would imagine, for all these different tasks with unique characteristics and facility, et cetera. It's just it'd be quite a daunting task to plan for all those. You mentioned about that the forces plans for a pandemic. So I imagine that includes a major part of health services involved with that pandemic planning.
Well, that's true. I would say, though, that the Canadian Forces as an entity has a lot of different capacity and capability that can be brought to bear to assist the civilian sector in a pandemic response. One key area, for example, would be the assistance to law enforcement agencies, perhaps assisting with border security, assisting with policing tasks, setting up security cordons and things like that. The Canadian Forces is no stranger to providing humanitarian tasks or humanitarian support, to include tasks like distributing supplies, distributing medications, things like that. We do have a disaster assistance response team that is part medical and part engineering support. So again, we're used to doing tasks like that, and we're often called upon in emergencies where the response is a well-organized, deployable group, and the military really can bring that force to the table. And each one of those force packages has its own integral medical support. Right. And so we might have a health services focused mission, or we might have another mission that has a health services supporting function to it.
Yeah. So switching to long-term care. I mean, that's the that's what everybody has seen on the media. Uniformed soldiers looking after vulnerable Canadians. If you told me 25 years ago that in 2020 up to 2,000 soldiers would be involved in caring for our elderly, I wouldn't believe you. But then here we are. How did that all come about? And I have some questions about the training and that sort of thing. But let's ask initially. It came from a request from assistance. How did you execute, or how did the health services execute those plans, the team makeup, and in the training? I wondered if you could comment on kind of those three touch points.
I'd be happy to comment on those things. So firstly, we received a request for assistance from the province of Quebec, where they really were having a lot of challenges in a great number of long-term care facilities, as I'm sure you'll remember. Mm-hmm. They originally asked us to provide, I don't remember, they didn't have a defined number, but we had spoken to them and sort of agreed to send a team of approximately 70 personnel, purely health services personnel, to go into 5 facilities. A couple days later, we got a request from Ontario to send the same sort of force package into Ontario. And then very quickly, Quebec realized that they needed a lot more help than that. So they asked us to send a lot more people. Now, the Canadian Forces Health Services Group operates a health system, so somewhat analogous to a provincial health system. We're responsible for primarily the primary care of military members, but we do also provide some secondary care and specialist services. But a lot of it we do buy from the civilian health sector. But the bottom line here is we're a small system, and we do have a day job. But we do have some capacity that we have for operational reasons, and so we were able to mobilize a good part of that force. But to really achieve the task that at hand, we needed to have more people involved, and so we had a large group of what we call general duty personnel assigned to each one of our teams. And these general duty personnel typically came from the Army, from combat arms. So infantry, for example, might have made up a part of this team. And our concept was to have a shift. So a shift would be a nurse, 6 personnel support workers, personal support workers, and perhaps 10 or a dozen of these general duty personnel. The general duty personnel.
And those personal support workers, sir, what do they do? What would their day job be in health services? Just to clarify for people listening.
So I'll just go back to the nurses first. So the nurses are all licensed nurses, and the personal support workers could have come from a range of different occupations. We started out using medical technicians and medical assistants. Medical technicians are folks who start out with paramedic training, so they're all paramedics, and then they have other training on top of that, so they're very, very well qualified. The medical assistants are reservists who have not done paramedic training, but they've received a lot of other medical training. But they're there to typically to assist the physicians in the work that they have to do in their units. But we deployed a whole range of different occupations, people of different occupations, into that personal support role. We had physicians go in a personal support role, which was very unusual. We had dentists doing this as well. We had physiotherapists and physician assistants. So we selected people from our clinical occupations, where these were occupations used to wearing gloves and gowns, used to handling patients. We did not send social workers, for example, to that role. So it was really quite an interesting mix of people that went. We tried as much as possible to use volunteers, so a lot of people put up their hand for this, and we were very happy to deploy them. And I think it was a very enlightening experience for them, and a very positive one. And I'll get back to that a little later on, because I just want to close off this question on the general duty personnel. Mm-hmm. So as I said, they would have been from the infantry and other parts of the army primarily, and their role was as porters, as people, carrying the laundry around, delivering food, and perhaps most importantly, cleaning surfaces, washing walls, things like that, really disinfecting these facilities. Because I think that was a huge problem, was there was a lot of contaminated surfaces in these facilities, and they really needed to have a small army go in there and clean the place down, which is what they did. And I think that was one of the keys to our success, actually, was more than just the clinical horsepower, but the disinfection horsepower. The training that was conducted, of course, for those people involved in the actual care of the residents, they all had some kind of a clinical background, and on top of that, we provided an online package for everybody to take that sort of covered some of the history of the problem, but about long-term care facilities, because as you could imagine, our personnel aren't used to working in long-term care facilities. So we provided a lot of general information. Once they reported to the base nearby to where they were going to deploy from, the base that they were going to deploy from, we provided another day or so of face-to-face training, which and we went through donning and doffing PPE. There was a mental health module, and just more information and practice on moving patients, using some of the equipment that might be found in a facility. And then on the first day or so, on reporting to a facility, there was an onboarding process typically where, again, the processes of that facility, the nuances of their equipment was discussed. So that's, just in a nutshell, just a summary of the training that our personnel had.
And you touched on the team composition, like you talked about a shift, like what would and I realize the nuances from the facility, plus or minus people, it might not be exactly the same, but did you have like sections, a shift of people? You were mentioning the composition. Were there multiple shifts? Was it multiple teams? What did a typical long-term care team from health services look like?
So a typical team was 2 shifts, although there were some facilities that just had 1 shift and some that had 3. But typically it was 2 shifts, and they would do 8 or 12 hours depending on the needs of the facility. And then over time, as the facility started to, as the conditions in the facility and the facility's own workforce started to return to work, adjustments were able to be made. And over periods of time, the conditions were right that we could extract our personnel and then move them to another facility.
And was that team like a 10-person team, a 6-person team, a 9-person team? And what was the composition? Like, was there a team leader?
Yeah, so there was a team with 2 shifts, and each shift had a nurse and 6 personal support workers, plus approximately a dozen general duty personnel. So that's per shift. So a team would be double that. And the team lead was a nursing officer. And that's somewhat unusual because typically a team lead for us would be a physician. But given the task at hand, we felt that in this case, a nursing officer was best suited to be leading these teams.
Yeah, for sure. It makes sense. And you mentioned about the training, the online package, and then some in-house training. Kind of where do those expertise come with regards to long-term care and the geriatrics? Because I imagine you mentioned that it's the health system in the forces is like a provincial health system. Most of the patients are between the ages of 17, 55, 58. Where did you get the training, the instructors, if you will, or the teachers to look after this vulnerable population?
Well, of course, we all train in the civilian sector, so all of our physicians and nurses and so on have had exposure to geriatric patients, although perhaps not recent exposure. We do have a lot of our nurses are embedded in civilian hospitals, and a lot of our specialists, medical specialists and surgical specialists, are also embedded in civilian hospitals. So we used our own experts, I suppose, people with the most current experience to help design this package. And I think an important point here is that it was approximately a 6-hour package. It was an orientation, if you will. And so the precision level of detail perhaps didn't require geriatric expertise to design it. But nonetheless, our people who went into the homes found the package to be very, very useful, actually. We got a lot of positive feedback on it. And our package has actually been used by other militaries around the world for preparing their people, or perhaps to use it as an example to create a program for their own country.
Interesting. With regards to the experience that these teams had in the facility, were there any a couple things that God forbid that we have to mobilize health services again in such a large way that would be done differently with regards to going into long-term care? Or did the process you feel was solid? It seemed solid, from us civilians watching it. So,
well, I think the deployment was a success. I think that our personnel made a huge difference. They certainly saved lives of people, and they brought hope and relief to not just the residents of these facilities, but to their families. And they brought comfort and support and raised the morale of the residents and the staff of those facilities. As I say, I've spoken to a good number of our people who went there. They felt confident in the training that they received, although it was abbreviated, and they felt that they had the tools they needed to do the job. And I've had feedback from provincial officials and staff of some of these facilities, and even residents. I had an email from a resident who had so much praise for the teams just showing up before they even started working, actually. But they were just so pleased to have fresh people full of enthusiasm and not worn out by the pandemic to date to come in there and sort of reverse the trend that had been in place.
Yeah, I found your comment interesting about the team makeup, and that really goes to show your job kind of defines your role, with the nursing being the team leader. And you mentioned you had physicians and physician assistants and med techs and medical assistants as PSWs, personal support workers. Were there any legislative challenges taking those professions, putting them in long-term care in Quebec and Ontario, with regards to credentialing? How did that work with those provinces?
Yeah, that was something that we thought long and hard about, as you can imagine. Certainly, for the first teams that went in, we were able to match the licensed professionals with licenses that they already have. In the military, we all have a license in a particular province, and we had quite a few who were licensed in Quebec and Ontario. So we were able to match that. But we ended up, at the end, because of the numbers required, we ended up bringing people from across the country to put into the facility. So we did end up with people who were licensed elsewhere. And on the nursing side and the physician side, we did seek a interim license for our providers, and that was granted very quickly. Within 48 hours, we had a license for those two. We did not seek licensure for the dentists or the physiotherapists, because they weren't going to be. It was a much clearer line in the role that they were going to be playing, and so they really just stuck to the PSW work that was at hand.
Okay, yeah, okay, that makes sense. You touched briefly about the morale of the soldiers and speaking to the staff. Have you noticed any other impacts on the soldiers that went into long-term care with their mental health, or the effect of seeing this? Have you noticed anything, or people that you spoke to with regards to the effect they had on working in long-term care?
Well, one of the things that we were worried about right from the very beginning was the impact on the mental health of our people, and some of what they saw could be traumatizing to some. Potentially, some people could have sustained a moral injury, depending on the situation that they were involved in. So that's why we included a mental health module as part of the deployment preparedness package. And it is something that we have built into the military sort of culture and fabric anyway. Right from basic training, we include these things in there. But of the people that I have talked to, and maybe it's still too fresh, but of the people that I have talked to, they have universally, to a person, been so positive about this experience. They say it was hard, it was hot, it was sad, they had to do things that they never expected to do, but they were proud. They were proud to be there, proud to make a difference, proud to be helping Canadians. We spend so much time helping people in other countries, and it's not very often we get to make a true difference, a measurable difference in our own country. And people felt that. And so that was, I think, a very positive outcome of this. Another thing that I think is a positive outcome is the cohesion and the particularly in the personnel support workers who are coming from so many different occupations. It has helped to raise some of the hierarchy in our organization, and I think that this will have an important impact going forward. The physicians and the dentists now have a much better appreciation for this kind of work, perhaps that some of the medical technicians might be more familiar with. And so I think that will help to strengthen our organization. So I think that out of this terrible, tragic situation that arose in our country, there are positives that came out of it, and positives for the military. I believe there will be positives for our society that will come out of this. And I do think that our health system, our society will make the necessary improvements in not just our long-term care system, but in our overall health system. A system I'm sure anyone listening would agree is not funded to do all the things it needs to do. And I think that we as a nation need to face up to that, and we need to invest in this very important part of our social fabric.
Right, and you touch on a really good point there with the last comments with regards to the heat and lens that the forces brought on long-term care, and of course we're all aware of those headlines from that report from, I believe it was one of the division commanders that submitted with an objective critique of what they've noticed in long-term care. Were you surprised or shocked at what was in that report that was, in the public sphere with regards to the multiple deficiencies and the way that some of these vulnerable Canadians have been cared for? Did that surprise you, what that was in there?
Well, I think it surprised a lot of people, myself included. But when you step back and look at it, perhaps it shouldn't, most of that perhaps should not be that surprising. This was a crisis situation. Mm-hmm. And of course, and different facilities had different experiences, and not every criticism applied to every facility. But I think a lot of the issues that were raised were really due to the fact that facilities were overwhelmed, staff were overwhelmed. Many of the staff were sick. Of course, the residents were sick. I think that the challenges can be broken down into several different categories. One of them, I think, is the response to the outbreaks in the facilities, the PPE requirements, the lack of sorting of COVID positive patients from the negatives. In some of the facilities, these people were not sorted; they were intermingled. So the infection prevention and control was not ideal, and I think a lot of that just has to do with being overwhelmed. There were also issues of, I think, facility management. Linens were running out. There were expired medications and things of that sort. And then I think the third main category is some of the standard of care issues that we saw. Issues around catheter management, issues around aggression of some of the workers who no doubt were very stressed and overwhelmed. But nonetheless, there was insults to some residents. Was forcible handling of residents in some places. There was, in a couple instances, sort of rushed feeding where mm-hmm. residents would choke and so on their food. So things that really should not happen under any circumstance, unfortunately, did happen. I think that this report exposed this. I think that long-term care facilities have not really been the focus of health systems. I suspect these things have been going on a long time, but this crisis exacerbated it considerably, and we just happened to find ourselves in the position where we were witnessing it, and so had to report it. I should say that by the time these observations were reported to the facilities before they were even reported up the military chain. And so the facilities were already taking corrective actions on these things prior to the report coming out. I think that's an important aspect to note. It wasn't that everything was kept quiet until this report came out. Actions were already ongoing to fix these problems.
Right. It certainly shed heat and lights, and your comments hit home. I think with the conscious of us as care providers with regards that long-term care has been neglected in the system for sure. You've had an amazing career, 30, 31 years. Did you ever think in your career that you would be ordering soldiers into long-term care in your own country of Canada? Did that ever cross? Did you ever think that would happen when this pandemic occurred?
Well, I did not think that we would be helping out in long-term care. Although I would say that, we in the military prepare for a lot of different things, and our pandemic response planning that we've done in the previous, over the years, has sort of highlighted the fact that we may need to augment the civilian health system somewhere. We just did not expect that it would be in long-term care facilities. We thought we might be providing care in prisons. We thought we might be providing care in isolated communities, or in assisting in acute care facilities in large centers potentially. But long-term care facilities was not something that was on the front of our mind when we were doing our planning. So in that sense, it was a surprise. But the fact that we're helping Canadians in healthcare is not itself a surprise.
Okay, got it. I see. I see the distinction and the commonality. One of the questions that some of the members would have, or somebody would have, was, the military is really good at speed and planning and logistics and organization. Are you ever concerned that? Do you ever? I guess what I'm trying to say. Do you ever ensure that before that request for assistance that they have exhausted all other options? Like, for me as a planner or an administrator on a civilian side, we'll call in the Army, they'll fix everything, or call the armed forces, they have a labor pool and the expertise. Is there a check and balance with that? I'm thinking with long-term care, you mentioned PSWs. I'm not going to name organizations, but I can think of other volunteer organizations. Was it the fact that the speed of organization that the forces could bring, or how do we address that? How do we make sure that we don't abuse the expertise that health services can bring in a crisis?
Well, we do. When we hear of a request for assistance, we do have a look at it and see whether this is something we in fact can do and should do. And we do provide some advice and feedback to the requesting organization on that. And I can tell you, we had requests for a lot of things over the past couple months that never materialized into a formal request. So there is a bit of give and take. A lot of organizations don't understand our limitations. A lot of organizations forget that there are many other parts of this country that might be asking for assistance as well. And we need to, I think in every jurisdiction, one needs to consider what else one can do with the resources at hand. And I know a lot of hospitals are already looking at this, how to use non-critical care staff to assist in critical care departments and emergency departments, things like that. I don't know if many jurisdictions looked at using paramedics to assist in hospitals, but I mean, that would be another option. I know students were considered, residents were given potentially more autonomy in some places. So there is a certain level of redundancy, I think, in every system. And one needs to look at that redundancy first. And the military should be an organization of last resort. You call the military when you really have exhausted your options. And and then we will do our best to respond, but understanding that we are small, we can only do so many things, and when we look at the national need, we need to be vectored in on the most important national requirement, not on just the first thing that comes up.
Okay, all right. And you mentioned when you were commenting on that, on using the military as a last resort when you exhaust other options. You also dovetailed on some lessons. You mentioned about maybe paramedics being used in different roles. You mentioned physicians and physician assistants being used in different roles. Are there lessons that we can adapt as civilians working in the civilian system from the health services support experiences so far? Is there things that we should knowledge translate right now from the armed forces response to our civilian practices within this COVID pandemic environment?
Well, I think we've learned many of the same lessons that everybody else has learned, but perhaps some examples are really around how do you achieve an effect, as opposed to how do you do something in the usual way that you do things. So that gets back to what we were just discussing, using paramedics in non-paramedic roles, but leveraging their expertise. So I think that's one thing that needs to be looked at. I think that having redundancy in a system is important. We do have a little bit of built-in redundancy for operational requirements in the Canadian Forces, and I think that that's helped us, and it's allowed us to respond to our own requirements as well as to be able to support in long-term care facilities. I think that it's important to have redundancy in medications and PPE. We fortunately have a good stockpile of PPE, not of all PPE, and this is one of the lessons I would say is important, is we ran out of gowns very fast, and we had a very difficult time getting gowns. At the beginning of our response, we were providing our own PPE to our personnel, but by the end, most of the facilities had enough of their own that they could spare and provide our people. But I think going forward, we need to make sure that we have redundancy. Just-in-time delivery for PPE and critical medications is not how we should be managing a health system. It does not lend itself to an emergency such as we have here. I think that those are the two main things. I don't know whether in Canada we could ever envision having a more formalized rapid reaction medical team that could be deployed somewhere in the nation, but I would say that's something that could be considered. But anyway, I think that's really, those are the types of things I would suggest as useful lessons learned. But I think we've all learned about supply chain. We've all learned about shortages of people, and I don't think our experience is particularly unique in that.
Okay, General Downs, we get a lot of questions. I think it was in Ottawa. It was discussed, or there was questions asked, and a lot of us didn't even realize, but there's a medical military intelligence cell that's in the armed forces. And that would be surprising to, I think, most people. And that's a shop, I believe, that's under your command. And what can you tell us, if anything, about what the medical military intelligence cell does, and even if that's the proper name of it?
Well, it is, we call it the Medical Military Intelligence Cell, and it is a small team of people who belong to the Royal Canadian Medical Service, but we actually second them to the intelligence command that exists within the military. We also have a person posted to the United States to work in their National Center of Military Intelligence in Maryland. The role of this team is sort of multifaceted. They help advise on risks that could occur during a deployed operation. For example, if we want to set up a camp in a particular location, they would be able to perhaps access information about what used to be on that site. Is this an old toxic dump site, or are there chemicals and radiological hazards that might be there that need to be that would require us to avoid that site. So that's one example of the things that they do. They do also monitor things like infectious diseases outbreaks, potential pandemics. So they're monitoring both the open source information, media, journals, things like that. But they also do have access to classified sources, as well as a very tight network of colleagues working in this medical intelligence space in other countries, principally in the so-called Five Eyes group: UK, US, Australia, New Zealand, and Canada. That's the Five Eyes group. And they share a lot of information about diseases, about health risks, about potential health hazards to deployed forces. So small team has a very big impact. Some of their products are used by other government departments at the federal level, and certainly we in the Canadian Forces rely on this information when we conduct operations internationally.
And the makeup of this team, it's physicians? Is it multi-trade team, or who's on this team?
Yeah, the makeup of the team is of three different occupations. We have bioscience officers, we have preventive medicine technicians, and we do have physicians. And the relative makeup of all of those does change over time. And we also do have other people external to that team, but who provide advice and input and assistance in the analysis of the information, who may not be embedded into the intelligence command.
Okay, very interesting. There's a few questions that when that unit kind of came on there, that people had. So thank you for sharing what you could about that team. We know that the Armed Forces provides an incredible amount of leadership training to its leaders. Training that's second to none. And you've been both a physician leader and a commander in humanitarian operations. You've been a physician leader in combat operations. In broad strokes, like what can we learn as emergency docs in our systems from the military about physician leadership? And I know it's a big topic, but just what do you think that we could translate from the military with regards to leadership qualities that we can bring to our emergency departments?
Wow, that is a big topic, and it's a very interesting subject for sure. But leadership. I think a lot of physicians, when you finish medical school, it's almost a scar in us that it's work. Physician work is clinical, but that's not true. Physician work includes administrative roles, it includes leadership roles, and academics, and so on. But there's this scar against all of these other things, and it's unfortunate. But I think all of us as physicians need to play some role in leadership, whether it's in your department, whether it's and I think we all do, in a code or in managing patients. But when one starts to become a leader at a more senior level, where one's running a department, where one's running a facility, there are different skill sets that are required. And I think to get those skill sets requires a few things. I think it requires some training, and there's some great programs out there that people can attend. But also getting experience. There is nothing like getting experience, both because you can apply what you've learned, but also you can learn you can find out what you need to learn, so that you can go and take an appropriate course and bring that back. But being observant, I think, is critical. Having the right mindset is critical. I think that one needs to be willing to take on responsibilities, even though you're all busy and so on. I think one needs to try it, give it a try, and learn from it. Watch others, see what other people do well, see what other people don't do so well, and try to shape yourself around those best practices and avoiding those that are less best practices. So I think that that's really what I've benefited from. My very first job in the military was I was put in charge of about a dozen medical technicians and a preventive medicine technician, and we were responsible for the health and welfare of a unit. And I learned so much from my team. They actually taught me about leadership, and that's also something we often don't think about, is how people we're leading actually are perhaps our best teachers. We can react to how they react to us, and through all of this, the final thing I think is really important is treating people with respect and trying to keep calm and realize that not everyone can be perfect every day. Well, nobody can be perfect probably any day, but you know what I mean. We need to tolerate, we need to nurture, we need to build people, and followers will follow people who will help them, guide them, and build them up.
Okay. General Downs, it's hard to believe, but the hour has gone by. On behalf of all Canadians, and on and on behalf of the CAPE membership, I just want to really thank you for responding to the call for our vulnerable Canadians, responding to the call in our long-term care facilities, and organizing and leading, from the front the response. I know that you're retiring soon. I want to wish you all the best in your retirement, and sincerely thank you for your incredible service to Canada. And, it was a real pleasure hosting you this evening. It was great to see you again on a personal note. And I'm sure our paths will cross again.
Well, thank you very much, Trevor, for your kind words. Thank you very much for the invitation to be here tonight. I really enjoyed participating. I hope this was interesting to all you viewers. And anyway, I look forward to perhaps seeing some of you in the future. And certainly for you, Trevor, I look forward to getting together at some point once this COVID dust settles.
Okay, thank you, sir. For those of you that are tuning in now or watching it later, please consider becoming a CAPE member. CAPE is your national voice for emergency medicine in Canada. And I want to thank the CAPE leadership for organizing both the COVID town halls in the spring and our national ground rounds. The next ground rounds are August 12th. And please consider joining CAPE and making our voice even stronger. Hope everybody stays safe and have a great evening.